Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Sanghee Hong, Assistant Professor of Medicine at Duke Cancer Institute, one of the leading transplant centers in the United States. And she's going to walk us through how she decides on various aspects of stem cell transplantation. Welcome, Sanghee.
Thank you so much for inviting me today for the talk today.
So we're going to get started, and I would say that obviously, generally two broad buckets of transplant, autologous and allogeneic. How do you decide who to give an autologous transplant to and who an allogeneic?
Yeah, so that's actually the first question most patients ask as well, and then also the community oncologists too. So when we give autologous stem cell transplant, the purpose of doing it is to give the stem cell rescue after high intensity conditioning chemotherapy for the patients with a hematologic malignancy such as multiple myeloma or lymphoma, although it's less used. And for the allogeneic transplant, it actually serves different purpose of replacing the patient's immune system to someone else's to induce what we call it as a graft versus tumor effect. So when we consider for the cancer that we think that we'll be able to cure with the high intensity chemotherapy or be able to prolong their next time to the progression, then the goal is to give the autologous stem cell transplant with a high intensity chemo followed by their own stem cells. If we believe that patients need more than just chemotherapy to get to that potential for cure, then our goal is to give conditioning, which can be chemotherapy plus or minus radiation, and followed by the donor cells, then that is the allogeneic transplant.
So what disease states generally, I know there's an overlap over here to a large extent, but broadly, what diseases do you go for an auto over an allo and vice versa?
So for now, the biggest indication for autologous stem cell transplant is multiple myeloma, followed by, while it is decreasing, still the non-Hodgkin's lymphoma, that is the second most common. And the allogeneic transplant, the highest indication is the acute myeloid leukemia, myelodysplastic syndrome, myeloproliferative neoplasms, acute lymphoblastic leukemia that has been progressed after the first line, and sometimes a relapse refractory CML to the lines of the TKIs or had a blast phase CML, or sometimes the severe aplastic anemia or the bone marrow failures. Those are some of the indications.
Thank you for that. So, how do you next decide what kind of donor you're going to use in the case of an allogeneic transplant?
Yeah, so actually, when we go over the sources of donor, we say that we look at multiple different things. So the number one most important thing is whether there will be the HLA or immune matched donors that are available for the patients. The biggest source of the HLA matched donor used to be match related donor. So those are generally like the siblings that have an HLA identical, the types. But more recently, starting around late 90s to more like nowadays, matched unrelated donor is actually more common of the types that we could find the HLA identical types of the donors. If the immune matched donor is not available, then we're looking for that are not completely immune matched, but close, and then we can safely bring for transplant. So those are haploidentical donors. Those are generally half immune match or sometimes a little better for those who are either children or sometimes the adult parents or sometimes a sibling that are not completely immune matched. Or sometimes we consider mismatched unrelated donor as a source as well.
So, it seems like you go for matched related donor first, matched unrelated donor second, and then either a haplo or mismatched. The haploidentical transplants obviously are a recent development. Are they as effective, and are the results similar to that obtained by related and unrelated donors?
So actually, so you're absolutely right that haploidentical donor has become really popular since I would say that last decade. Now the data is saying that the outcomes are actually really similar in terms of even for the long-term outcomes. So, from the historical perspective, we still want to see if we can have, the HLA matched donors. But if not, then we can safely bring them for transplant using the haploidentical donors.
So are there situations where you may actually go for a haplodentical donor over a mismatched donor?
So you're talking about the mismatched unrelated donor,
Or
correctly?
or a matched unrelated donor? I understand that those may take time sometimes. Have you, in certain circumstances, favored a haplodentical transplant just because it's more you're able to get the donor quickly, and sometimes the disease is perhaps very aggressive and you don't want to wait?
So actually, there are a few things besides the HLA match when we're considering for the donors. So you are, I think, tapping onto the issue of the donor age, donor sex, their kind of the infectious history and whatnot. So you're right. I think that starting with the pandemic, we are seeing time to time that it takes a little bit longer to actually get the unrelated donor to be lined up. And personally, as an experience, even after we see in the donor registry that there are, for example, close to 20 immune matched donor, sometimes when we contact them through the National Marrow Donor Program, sometimes we are not able to have the answers come back within the timely manner. So in reality, when we're doing the donor search, we actually search for all donors at the same time. So those are the siblings, children, adult parents, if I consider them like less than 60. And also for, unrelated donors that are, if they're completely matched, I'll go for it. If we don't see that they're readily available, if no haploidentical, the family donors available, then I'll go ahead and type those ones as well.
So if you have more than one matched unrelated donor available, how do you decide which one of the several that you will pick as the donor?
So actually, that's a really good question. And we time to time look at all these donors and have, for example, they are 10 out of 10, and how do we decide who to go for? So there are a few things like sex match, and then if there are how their immune status, for example, their CMV status. Based on the patient's CMV status, I might want to match the donor CMV status. We look at the ABO blood type to see if we can match them if possible. If the patient is on the heavier side, I'm trying to look to see if the donor itself is also not too light to enable to get enough of the cell doses. We're also looking to see if there are other IDMs or other issues. And even among 10 out of 10, sometimes some of the donors are 12 out of 12 or 11 out of 12 favorable mismatch donors. And those are sometimes more favorable than just 10 out of 10, or when you look at it as 10 out of 12.
So you've decided on an allogeneic transplant, you've decided on your donor. How do you decide what to request? Bone marrow, peripheral blood, or obviously cord blood is separate, but how do you decide between these sources of cells?
So actually starting after pandemic, our centers, the transplant center practice has been kind of shifted, and I'm sure a lot of the adult blood and marrow transplant centers practice has been shifted more towards a peripherally collected blood stem cells, mainly because of the ease of getting the OR spots and whatnot. But sometimes for some other indications like severe aplastic anemia, that we have to get the bone marrow as the source of the transplant. One thing that we did not talk about is the cord blood. So actually part of the donor search, we do look at the cord blood as a donor option as well. Some other indications, for example, like myelofibrosis, that we really want to make sure that they have a good chance of engrafting. Sometimes the cord blood is not seen as the first options, and obviously cord blood is one of the alternative donor sources. So those are not generally as preferred as the HLA identical siblings or HLA matched unrelated donors. In terms of the looking at the rest of them, I would say that in we had a prior studies that were published in less than 10 years ago stating that bone marrow as a source of the transplant have a better long-term outcomes. Those are quality of life outcomes or the chronic GVHD outcomes compared to peripheral blood stem cell, the donor sources. However, now when I'm looking at the patients who get transplanted with these PBSCs, they are actually doing a really good outcome. So I do think that you will see more and more centers preferring the PBSCs unless there is an indication they're having to do a bone marrow. And of course, if the donor is coming from the cord blood sources, and they are coming as the cord bloods.
So it seems like with the bone marrow, there's less chronic GVHD, so diseases that are not as aggressive, where graft versus tumor effect is perhaps not as needed, as you mentioned in aplastic anemia, bone marrow is still preferred, or the chronic leukemias. But acute leukemias, maybe you need more graft versus tumor, and that is where peripheral blood perhaps has a better chance. Is that what I'm hearing?
Yeah, I think the short term, the benefit of the peripheral blood stem cell is that it actually has a little bit shorter time to the engraftment when you compare to the bone marrow sources. So it has about like the 2 to 3 day advantage. In the longer term, I don't think that there is a lot of differences in the graft versus leukemia effect of the bone marrow versus the peripheral blood stem cells.
Then, as far as cord blood goes, it appears that you mentioned that it doesn't have enough stem cells, and that's why you kind of are a little hesitant. So understand that it's more so in a pediatric literature that you still see cord blood, and in adults, there's this controversy between should you use cord blood or should you go for a haploidentical transplant? How do you decide in your own practice between these two sources, haploidentical versus cord blood?
So actually, Duke University is one of the kind of the high volume center for the cord blood. Main reason is that we have a really robust program using the omidrucel transplant. So you
Okay.
will see that we are using more of that now manipulated single unit, the cord blood cell transplant, probably compared to some of the other centers that are doing it. When we're considering the cord blood transplant, I think that there are some of the advantages that double the unit, the cord blood transplant would have. So number one is that I think that among all the donor types, even considering for the haploidentical donor transplant, cord blood probably will be the fastest in terms of time to be able to get the actual donors because they're stored. So once you're able to get the typing in their hands, which should take in about 48 hours, it is a type that you'll be able to bring to transplant actually the quickest. For that, I just mentioned earlier about the omidrucel transplant. It takes about 4 weeks for that omidrucel unit to be produced from the manufacturer to get into your center to be able to use. So it requires some of the coordination. So generally, I think that the omidrucel transplant has a really fast recovery of the neutrophils and platelets and whatnot, but it requires some of the careful consideration and then the close monitoring even from the get-go.
So as far as then the conditioning goes, the chemotherapy and or radiation that we give these patients in preparation for their transplant, I understand that broadly we have two types of conditioning, myeloablative and reduced intensity. Could you give us a little idea about how they differ and where you tend to use one versus the other?
Yeah, so generally, there are some of the diseases, for example, like severe aplastic anemia, that we don't have to give patients a myeloablative conditioning. Then we usually go for non-myeloablative or reduced intensity transplant. In terms of the patients who are needing that additional chemo or chemo radiations to bring the disease status to at their best, then we are considering whether patients can tolerate the myeloablative conditioning. So those are such as patients who are going for transplant with acute leukemias or myelodysplastic syndrome, that we believe that patient would benefit from that effect of the conditioning intensity. Then I think that we consider if we can give them myeloablative conditioning, which generally for my own practice would reserve for patients who are less than 60 or 65 years of age without major comorbidities. If they do have those comorbidities, then my preference is to bring them with a reduced intensity conditioning, but really plan for their pre-transplant chemotherapies to have them achieve the best disease status possible to go for transplant. But obviously, there are some of the situation, for example, like someone who is having a very aggressive acute myeloid leukemia, that we just bring them close enough to getting into complete remission, but we believe that they might need a little bit additional chemotherapy, but patient is robust. That is like the perfect situation that we consider that we need that myeloablative effect for them to be able to have the best outcomes of allogeneic transplant.
So it seems like myeloablative transplants are a little more toxic, but a little more effective in terms of aggressive disease, and reduced intensity transplants are a little gentler, but have a little less a chance of controlling aggressive disease. So it's just, I understand then, striking that right balance, and it is as much art as it is science for each individual patient.
Correct, yes.
Okay, so then as far as these conditioning regimens, I understand some of them have chemotherapy alone, and some of them have a mixture of radiation and chemotherapy. So how do you decide which regimen to use broadly, radiation-based versus non-radiation-based?
So for my own practice, I usually have few of the regimens that I have chosen based on what disease indication they have. For example, for myeloablative, reduced intensity, non-myeloablative, so that my decision is rather simple in terms of what patients can do. And some of the disease indications like acute lymphoblastic leukemia, that where we really need to give the radiation the effect to go for the extramedullary, so sanctuary sites, then I really want to incorporate the high dose radiation, the TBI, as a part of the conditioning. One of the most commonly used the reduced intensity or non-myeloablative conditioning in my practice is called as a fludarabine, cyclophosphamide, and total body radiation. That is incorporating the radiation while we're giving a very, very low dose chemotherapy. So combining those are really a key in terms of modulating for their toxicity, and as well as trying to, give the best chance for the donor graft and graft in.
So what is the downside of a radiation-based regimen?
Well, so there are the long-term side effects of the radiation that we always need to watch for. So those are like the secondary cancer, sometimes pulmonary fibrosis. I recently also had in a situation that I just learned that I cannot give even that 300 centigrade of the total body radiation for some of the patients who have a pacemaker dependent arrhythmia. So there are some of the indications that you really need to be careful about those.
And then how do you decide on what to do for graft versus host disease prevention?
So when we have patients who have selected the conditioning regimen, they are usually in the literature with associated GVHD prophylaxis. So those are the ones that we follow. But now with the recent study with the POSI as the GVHD prophylaxis, if we're in an indications to be able to use the POSI as part of the GVHD conditioning, because of that study, the CTN has used the POSI mycophenolate mofetil with the tacrolimus. That is generally my preference in terms of the GVHD prophylaxis.
So it seems like for the longest period of time, a calcineurin inhibitor plus or minus methotrexate perhaps was the treatment, but then now with the post-transplant Cytoxan, a lot of people are shifting from using it not only in haploidentical transplant, but also unrelated and
Yep.
possibly in the future, fully related transplants as well. So as far as post-transplant Cytoxan goes, obviously Cytoxan is a drug that's been around for a long time. Um, it seems a little counterintuitive to give Cytoxan post stem cell infusion. Doesn't it kill the stem cells?
That is actually really, really good question. So the post transplant Cytoxan is given on day +2 and day +3 of the post transplant. And then when the scientists did this study, what we found was that the donor T cells are most active on that 48 hours after stem cell infusion. So giving an analogy, basically the donor cells are coming in, there are T cells in there, and then when they see the recipient body that are injured because of the conditioning chemotherapy or radiation, those T cells actually get activated and start causing the acute GVHD. So the post-transplant Cytoxan really goes in the time period that these T cells would become activated and start to be different. So then it is be able to actually hone in just by killing those activated T cells only. And that is what is fascinating about it. So for post-transplant Cytoxan, you're right, when the GVHD prophylaxis utilize a post-transplant Cytoxan, it often delays the engraftment for about another 2 to 3 days. But so far, we are able to use it safely, and it has not increased the risk of the graft failure.
And I think partly maybe because certain enzymes like aldehyde dehydrogenase are present in the stem cells that kill away the
Kill away,
cytoxin,
yep.
doesn't kill the immature progenitor. So that's really, I guess, a seminal finding. Now, as far as infection prophylaxis goes, how do you uh, prophylax for infections? Obviously, that's one of the major issues other than graft versus host disease that our patients run into trouble with.
Yeah, so I think that for autologous stem cell transplant, we often do, so there are center practice chain differences, but in our center, we give acyclovir bacterial prophylaxis, usually either levofloxacin, or we could sometimes give ceftiofur, and then the fungal prophylaxis with the fluconazole. For patients who are going through the allogeneic transplant, we generally give acyclovir or sometimes the valacyclovir. And then that same bacterial prophylaxis with the levofloxacin or preferred versus a ceftiofur. And then the fungal prophylaxis really is the posaconazole or voriconazole that are having the better mold coverage. And now that we know from how the letomavir has changed our practice for the CMV prevention, we're giving the letomavir for patients who are having the CMV positivity from that time of the engraftment until at least 3 months post-transplant. And in terms of the duration of these prophylaxis are somewhat different. So for autologous stem cell transplant, for that fluconazole and then the bacterial prophylaxis usually can stop after their engraftment, which happens in about 2 weeks or so. For the allogeneic transplants, we usually can stop the bacterial prophylaxis once they're not neutropenic. The letomavir usually about 3 months. If they're in a higher risk, that we give about 6 months. And then the fungal prophylaxis, really depending on their generally degree of the immunosuppressive. And also the herpes prophylaxis usually continues at least until the time that we are able to complete the shingles vaccinations.
So these transplants, do you have an upper age limit at which you kind of say, oh, you're not a transplant candidate?
Yeah, so we actually say that there is no true upper age limit, but there is a physiologic age that we don't consider transplant as good fit for them. So I usually get really careful once they are around 75 or so, but I do transplant for patients who are above 75. I have not yet had a patient who had above age 80 who are going for a transplant. But for some of the autologous stem cell transplants, I do know that they are still being considered.
So obviously, a lot of advances being made, and these are areas where I'm sure we'll have new developments. And I hope I can turn to you for in the future for additional programs to tell us about these advances as they occur. I'm really grateful to you for having spent the time to educate the audience about how you think through stem cell transplant. And I can't thank you enough.
Oh, thank you so much for inviting me again and having a chance to chat. Thank you.
Thank you.